our webinar this afternoon. I'm ClinData Insights Marketing Manager, and I'm excited you decided to join us today. This webinar is hosted by ClinData Insight. We are a biometrics consulting firm based in the San Francisco Bay Area. We specialize in biostatistics, statistical programming, CDISC implementation, and clinical data management. Today we are discussing propensity score analysis and observational studies presented by Dr. Quinn Nee. A little housekeeping before we get started. From now until the end of the webinar, all attendees will be placed on mute so that we can remain on track. If you have any questions at any time during the webinar, you can leave them in the chat box at the lower right-hand corner of your webinar screen. And if you just type in your question and press send, it will be a public question. If you down click on that to and you send just to ClinData Insight, it will be private. Questions will be answered at the end of the webinar. In addition to this webinar will also be recorded and later placed on our website. We estimate the webinar to end in about 50 minutes, but if there are a great amount of questions, we can stay a little bit longer to get those answered. If we run out of time at the end of the hour, to be mindful of everyone's time, any remaining questions will be answered offline by Dr. Nee, and the answers will be placed on our website along with the slides. Now, without further ado, we will turn the time over to Dr. Nee. Our presenter today, Quinn Nee, PhD, is the Director and Head of Biostatistics here at ClinData Insight. Dr. Nee has over 14 years of clinical statistic experience in the pharmaceutical industry, and she is passionate about providing innovative trial design solutions to support clients' needs, especially in oncology therapeutic area. Over the years, she has supported all phases of clinical studies in multiple therapeutic areas. She is very experienced with statistical methodology and study design. She also has firsthand experience in multiple successful regulatory submissions. Dr. Nee completed her PhD in biostatistics at the University of California, Los Angeles. She received her Master's of Science in Statistics from Beijing University and her Bachelor's of Science her Master's of Science in Statistics from Beijing University and her Bachelor's of Science in Mathematics from Tsinghua University. Now I will hand the time over to Dr. Nee.
Thanks, Alison, and thanks everybody for being here today. And here's the outline of my presentation today. I will first give a short description of background information and the motivation for this research, and then we'll give an introduction of propensity score methods, followed by simulation results. I will conclude my presentation with discussions. So here's some background information. In recent years, there have been increasing interest in utilizing observational or non-randomized studies to generate real-world evidence and support regulatory decision-making. FDA has a long history of using real-world evidence to monitor and evaluate the safety of drug products after they are approved. And in limited instances, FDA has accepted real-world evidence to support drug product approvals, primarily in the setting of oncology and rare disease. And when approval is based on a single-arm interventional trial, the supportive real-world evidence has consisted of data on historical response rates drawn from chart reviews, standard access, and other practice settings. And in the end of year of 2018, FDA published a framework for real-world evidence program. The scope of this program is to evaluate the potential of real-world evidence to support changes to labeling about drug product effectiveness, including adding or modifying an indication. For example, a change in dose regimen, or route of administration, or adding a new population, or adding comparative effectiveness or safety information. And an example of using real-world evidence to support drug approval is blincyto. Blincyto was initially approved under accelerated approval for the treatment of pH-selective RRALL, and it's based on a single-arm phase 2 study, and the primary endpoint of the phase 2 study is complete remission rate and the duration of complete remission. The response rate of the single-arm study was compared to historical control weight from 694 comparable patients who were extracted from over 2,000 patient records from EU and US clinical study and treatment sites. And the FDA requested a further study in a randomized controlled trial, which was the TOWER study, to verify the clinical benefit seen in the phase 2 study. In observational studies, treatment selection is often influenced by subject characteristics. Therefore, one should account for systematic differences in baseline characteristics between treated and untreated subjects when estimating the effect of treatment on outcomes. And the propensity score allows one to design and analyze an observational or non-randomized study so that it mimics some of the features of a randomized controlled trial. Yet there are some technical challenges of using the propensity score method. The first challenge is that although propensity score adjustments are widely used in observational studies, there is a lack of consensus as to which variables to include in the propensity score model. Second, there's a lack of assessment on the performances of propensity score methods, particularly for non-collapsible treatment effect estimates, such as odds ratio or hazard ratio. So the objectives of this research is to first compare the performances of different strategies to choose covariates into the model for propensity score, and second, to compare the performances of 4 commonly used propensity score methods in analysis. Those are matching, stratification, inverse probability of treatment weighting or IPTW, and the covariate adjustment using the propensity score. And now I will give an introduction to propensity score analysis method. Here's an overview of propensity score method. First of all, what is propensity score? The propensity score for one particular treatment is defined as the probability to receive the treatment conditional on observed covariates. And the propensity scores might be used in 4 ways. First is to be used as a covariate in a model along with treatment for the outcome analysis. And the second is to be used as weights for the observations in a crude model. And the third is to be used as values to stratify data to form more comparable groups. And lastly is to be used as values on which to match a treated to an untreated observation, and then using the matched pair in the analysis for outcome. And the method to use propensity score as a covariate in a model is straightforward. So I'm going to skip the description for that and talk about the details for the other 3 methods. So the first step is to develop the propensity score. The most conventional method, which is method 1, is to use standard logistic regression using treatment received as independent variable and the baseline characteristics of covariates. With modern techniques in big data, machine learning techniques such as PART or random forest are also used to develop a propensity score. I'm not going to talk about the machine learning techniques in this presentation, and I will recommend those who are interested to refer to the publication of Brian Lee et al. And the propensity score for one particular treatment is calculated as the predicted probability to receive that treatment conditional on observed covariates. And I wanted to emphasize that propensity score analysis methods cannot be used at all situations. And we should check the overlap or common support of propensity score between the treated and untreated groups before we go ahead and do the propensity score analysis, such as stratification or weighting. When treated and untreated groups include non-overlapping sets of values, that means individuals in one group have values on some of the covariates that do not exist in the other group. Then the usual methods for controlling confounding may not work. An extreme case would be a scenario that the treatment assignment is completely confounded by a covariate, and there is no way to distinguish the treatment effect from confounding effect. And how much common support do we consider sufficient? We consider the overlap or common support to be sufficient if at least 25% of the propensity score in the untreated group overlaps with the inner 95th percentile of the treated group in a box plot. And this is just an illustration of a case that the propensity score method will not work. In this example, subjects with low propensity scores are never treated, while subjects with high propensity scores are always treated. And therefore, we cannot use the propensity score method, since there's a lack of common support. Now I'm going to describe the IPTW method, which is a weighting method. In this method, weight is defined as the inverse of the probability of receiving the treatment that the subject actually received. So for subjects in the treated group, the weight is defined as 1 over propensity score. And for subjects in the untreated group, the weight is defined as 1 over 1 minus propensity score. And this method creates a new pseudo-population by weighting. For subjects with a very low probability of receiving the treatment actually received, the weights might be too big, and they are considered outliers. To address this issue, we propose to use stabilizing inverse probability of treatment weighting, or IPTW. In this method, the IPTW is multiplied by the marginal probability of receiving the actual treatment received. And if after stabilization, outliers still exist, then we can do further trimming. And in the trimming approach, outlier values are trimmed to be the maximum of non-outlying value. The IPTW method or the SIPTW method can make comparisons fair. The IPTW mimics the effects of randomization with randomization ratio of 1:1. And SIPTW mimics the effects of randomization with a ratio of N1 to N2. Here, N1 and N2 are the sample size of treatment arm 1 and arm 2 respectively. And the IPTW or SIPTW can create groups which only look randomly different with respect to observed covariates. And now I'm going to talk about more details for the stratification method. Although there are multiple ways to do stratification, the most common approach is to use 5 approximately equally sized strata defined by the quintiles of the propensity score. And the effect of treatment on outcome is estimated within each strata. And then the stratum-specific treatment effects are pooled to get an overall treatment effect estimate. And Rosenbaum and Rubin demonstrated that by doing stratification based on the quintiles of the estimated propensity score, eliminates approximately 90% of the bias due to the measured confounding. And now I'm going to talk about the matching method. And the PS matching method creates matched sets of treated and untreated subjects with similar values of propensity score. Although there are different approaches to do the matching, the most commonly used approach is to use the nearest neighbor pair matching without replacement within specified distance of the propensity score. And for more details, you can refer to the paper of Austin. Okay, so now I'm going to share the simulation results. And before that, I'm going to introduce some definitions. So first definition is confounder. And in this diagram, a variable X is correlated to both treatment T and the outcome Y. And this kind of variable is a confounder. And then conditional effect and marginal effect. A conditional effect is the average effect at the individual level of changing a subject treatment status from untreated to treated, while marginal effect is the effect of the population level. That means the difference in outcomes between two populations that are the same, except that one population, everyone is treated, and in another population, everyone is untreated, such as in a randomized trial. And then the collapsible treatment effect. A measure of treatment effect is said to be collapsible if, in the absence of confounding, the conditional and the marginal measures of treatment are the same. Differences in means and risk differences are collapsible, while odds ratio and hazard ratios are not collapsible. And this is the first simulation example. In this simulation, we mimicked a non-randomized study with 3 measured covariates, X1, X2, and X3. And those covariates are identically independently distributed as standard normal. And the sample size for the study is 200. And the treatment is either active or placebo. And we assign the treatment through a logistic regression in this equation. So you can see the treatment assignment is influenced by covariate X1 and X3. And the outcome is response or non-response, and it's simulated through logistic regression model. And you can see that the outcome is impacted by treatment and the covariate X1 and X2. And those coefficients, A1, B1, B2, A3, beta, measure the strength of association between the covariates and the treatment and the covariates and the outcome. And here, beta is the association between treatment and the outcome Y. Okay. And we used 4 different approaches to develop the propensity score. The first approach is to use all covariates, that means X1, X2, and X3, to to develop the propensity score using logistic regression. And the second approach is to only include the covariates that are related to treatment. Those are X1 and X3. And the third approach is to only include the covariates that are correlated to outcome. And those are X1 and X2. And the fourth model is to only include the true confounder. In this scenario, it is X1. And after we get the propensity score, then we use stratification, matching, IPTW, and the PS adjusted as covariates to do the outcome analysis. And we use the 5 stratum for the stratification method, and we use the 1-on-1 matching for the matching method, using greedy nearest neighbor without replacement within a caliper of 0.1. And we also use the crude analysis. That means the unadjusted analysis. It is a through logistic regression for outcome without any adjustment for covariates. And we also looked at the logistic regression for outcome, including all covariates as predictors in the model, along with the treatment. And lastly, we include only the true confounder for the propensity score development. And then we add the covariate that is only related to outcome, but not to the treatment, that is X2 in the regression for outcome. And this is a summary of the simulation results for the stratification method. And the results were based on 1,000 simulations. We summarized the bias and the mean squared error for the estimate of beta. When beta equals to 0, we assessed the type 1 error. And when beta equals to 1, we assessed the power of testing. And we varied the association between X3 and the treatment to be -3 to -1.5 in order to assess the impact of including covariate that is only related to treatment but not with outcome into the propensity score. When the association measure of this covariate and the treatment is from big to small. And when beta equals to 1, the conditional odds ratio is about 2.72, which is a moderate odds ratio commonly seen. And the marginal odds ratio is about 2.3. And you can see from the table that model 5, which is a crude model, always yielded a biased estimate and a big mean squared error and poor type 1 error control, and also a low power. And the stratification method significantly reduced the bias and the mean squared error from the crude analysis. And it has good control of type 1 error and better power compared to the crude analysis. And models 3, 4, and 7 have similar performances, and they consistently perform better compared to model 1 and 2. So we recommend not to include the covariates that are only related to treatment but not related to outcomes into the development for propensity score, since that may lead to increased mean squared error and reduce the power. And this is particularly noticeable when the association between X3 and the treatment is strong. And model 6 is the conventional multivariate regression instead of the propensity score method. It has less power compared to model 3, 4, and 7. We can see some systematic bias, and this is expected since the propensity score stratification is estimating the treatment effect somewhere between the conditional and the marginal effect. And the next is for the result from the matching. And it is kind of similar to the stratification method pattern. So you can see that the crude model yielded biased estimate, big mean squared error, and poor type 1 error control, and no power. And the matching method significantly reduced the bias and the mean squared error from the crude analysis, and has good control of type 1 error, and better power compared to the crude analysis. And model 3 and 4 have similar performances, and they consistently perform better than model 1 and model 2. So we still recommend not to include the covariates that is only related to treatment but not related to outcome into the propensity score development. And model 6 is the conventional multivariate regression instead of the propensity score method. And it performs better than the match method. This might be due to the limited sample size. We cannot find a match for all the treated subjects. So we have a reduced sample size for the matched data set. And systematic biases were also seen for beta. And this is expected since this PS matching method is estimating the average treatment effect for the treated population, not for the overall population. Okay. So this one is the summary of result for the SIPTW weighting. And we can see that SIPTW significantly reduced the bias and the mean squared error from crude analysis, and they had a better power compared to crude analysis. And model 3, 4, and 7, they have similar performances, and they consistently perform better than model 1 and model 2. So again, we recommend not to include the covariate that is only related to treatment, but not related to outcome into the propensity score development. And systematic biases away from the conditional treatment effect were seen. This is expected since this method estimated the marginal effect instead of the conditional effect. And you can also see there's a big type 1 error for the SIPTW weighting, and I'm going to discuss about it later. Okay, so here is a summary for the method of using propensity score as a covariate in the outcome analysis. And model 3 and 4 perform better than model 1 and 2. And the power of model 6, that is the conventional multivariate regression, is less than model 3 and 4 using propensity score adjustment. And also, this method has smaller bias from a conditional treatment effect compared with stratification matching or SIPTW method. This is expected since including the propensity score as a covariate in the outcome regression model is kind of estimating the conditional treatment effect. Okay. And now I'm going to the second simulation example. And this simulation mimics observational study with 300 active subjects treated with active treatment and 600 subjects treated with placebo. The distribution of baseline characteristics by treatment group is summarized in the next page. And the outcome is progression-free survival. And we simulate the progression-free survival through an exponential distribution with the hazard rate in this equation. And we have the first step to develop the propensity score using logistic regression. And the second step is to apply stratification, matching, IPTW weighting, and the covariate adjustment method based on propensity score. And we estimate beta from Cox regression model. And then we assess the bias, mean squared error, and type 1 error rate, and the power for beta from 1,000 simulations. And this is the summary for the mechanism to generate baseline characteristic variables. And the variables in orange are true confounders. And the variable in purple only associate with treatment, while the variable in green only associate with the outcome. Okay. And here is the summary for the situation when there's no treatment effect. That means beta equals to 0. And we summarize the stratification, matching, SIPTW weighting, and including the propensity score as covariate. And we assess the model 1, 2, 3, 4. Model 1 is to include all covariates. Model 2 is to include all treatment-related covariates. Model 3 is to include all outcome-related covariates. And model 4 is to only include the true confounder. And we also included the results from the crude, that means the unadjusted analysis, as a bench. And another bench is to use the conventional multivariate Cox regression by including all the covariates as predictors along with treatment. Okay, so you can see that the crude analysis, that means the unadjusted analysis, have big bias and the mean squared error, and the type 1 error is intolerable. And all the propensity score methods reduce the bias from the crude analysis. Although the SIPTW method has a poor control of type 1 error. This might be due to the systematic bias in favor of placebo and small mean squared error. And further, this method is sensitive to outliers of weights, and the trimmed SIPTW might perform better. And you can see that the bias is minimized for stratification and matching if you only include the true confounders into the propensity score development. And for the method of using the propensity score as covariate, the bias is the smallest, and that is expected, since this method is estimating the conditional treatment effect, while the stratification is estimating the effect somewhere between the conditional treatment effect and the marginal treatment effect. And the matching is assess the average treatment effect for the treated population, not the whole population. And the SIPTW method is estimating the marginal treatment effect instead of the conditional effect. Okay. And now we change the beta to be negative 0.1. And this indicates weak treatment effect on the progression-free survival. And when we set beta to be negative 0.1, the conditional hazard ratio is about 0.9. And the marginal hazard ratio is about 0.91. And you can see that all the propensity score methods reduce the bias from the crude analysis. And the models 3 and 4 perform better than model 1 and 2. And there are some systematic biases seen in stratification, matching, and IPTW methods. And again, this is expected as I explained for the previous slide. And then I changed the beta to be negative 0.3. This indicates a moderate treatment effect with the conditional hazard ratio to be 0.74 and the marginal hazard ratio to be 0.76. And in this simulation, the stratification method and including the propensity score as covariate in model 4 have better power than the conventional multivariate regression. Okay, so now we go to the summaries of simulations. Including two confounders in propensity score can effectively reduce bias of the treatment effect estimate. However, including the variables that are only related to treatment but not to outcome into the propensity score could yield bigger bias and mean squared error compared with only including the confounders into the propensity score. And Brookhart suggested to include all covariates that are predictors of outcome into the propensity score. So he even went to the extreme that even for a randomized study, you could still use the propensity score adjustment, since that there's no guarantee of perfect balance of baseline characteristics even for a randomized study, especially when the sample size is small. And in that scenario, the covariates that are predictors of the outcome were still unbalanced between, slightly imbalanced between the treated arm and the untreated arm, and is considered as an empirical confounder. And I think this is controversial, since although the inclusion of such variables into propensity score might increase the precision of estimate, according to the paper of Brookhart, the interpretation is a problem, since this is anti-intuitive to the definition of propensity score. And also, I think whether to include variables that are only predictors of outcome but not related to treatment into propensity score should depend on the strength of the correlation between such variables and the outcome. And I prefer to only include the true confounders into propensity score and adjust the other outcome-related variables in a regression model for outcome. And I think sensitivity analysis are helpful. There are some systematic biases seen in stratification, matching, and IPTW methods for the estimate of odds ratio and hazard ratio. This is expected since the odds ratio and hazard ratio, they are non-collapsible treatment effect measurement. And for stratification and the IPTW method, those methods kind of estimate toward the marginal effect, not the conditional effect. And for matching, the bias is expected since the matching estimates the average treatment effect over the treated population, not the whole population. And the bias seems to be minimized, and actually I think it's pretty good when we only include the real confounders into propensity score development. And in my simulation, using propensity score as covariate in outcome regression consistently yielded the least biased estimate among the 4 propensity score analysis methods. And further research needs to be done on how to choose treatment effect measures, especially for time to event outcome. For the binary outcome, we could use risk difference. That is a collapsible treatment effect measurement, and that is easier to interpret. And the conditional treatment effect is equal to the marginal treatment effect if we use risk difference. Okay, so now I'm going to conclude my presentation soon with discussion, and then followed by Q&A. So first, use of propensity score has increased substantially over the past few years, although the reason is unclear. And the possible reason might be frequent citation or presentation using this method. And the propensity score method can effectively reduce confounding effects. And it has been controversial whether the propensity score method can give better estimates of drug effects than those obtained from conventional multivariate regression approaches. And when there are unmeasured confounders, neither the propensity score method nor the conventional multivariate method can fully control confounding. And the randomized controlled study is still the golden standard. And there are some logistic issues to apply the propensity score method. In general, the mechanisms of treatment assignments is unknown in observational studies. And we recommend to get clinicians' input to get a list of baseline characteristics that are potential prognostic factors to start with. And we recommend to check the balance of those baseline characteristics to identify possible confounders. And also, logistic regression is commonly used to develop propensity score. However, this method requires assumptions regarding variable selection, the functional form, and the distribution of variables. And if any of these assumptions are incorrect, then the covariate balance may not be achieved. And this might result in biased effect estimate. And Brian Lee et al. Discussed the developing propensity score using machine learning method. And boosted CART and random forest provide excellent performances to balance the baseline characteristics. And these techniques may be considered for future research, especially when the number for confounders might be big. And here's some recommended implementation with propensity score. So the first step is to get a list of possible prognostic factors from clinician. And the second step is to check the balance of baseline characteristics. And the third step is to develop propensity score using the list of baseline characteristics. We can either use the whole list or unbalanced ones. And the fourth step is to check the common support of propensity score between two treatment arms. And the last step is to do outcome analysis adjusted by propensity score, such as stratification, matching, weighting, or including propensity score as a covariate. And when using the propensity score analysis method, we suggest to choose one method as a primary analysis and use multiple analysis methods or conventional multivariate regression or sensitivity analysis. And the consistency of results may strengthen the conclusion, and the sensitivity analysis may provide a range of treatment effect size. So this is the conclusion of my presentation. Any questions?
Thank you so much, Dr. Nee. So now we will go ahead and take some time for questions. As a reminder, if you do have questions, you can type them into that chat box on the lower right-hand corner of your screen. If you don't see this chat box, you might have to open chat, and that would be in the bottom bar of your webinar screen. So we do have a few coming in. First, we'll start with which propensity score analysis method do you recommend?
I think it's hard to say that one is universally better than the others. And I think that sensitivity analysis are always recommended. And just based on my simulation example, including propensity score as covariate in the outcome regression seem to perform best. But it is because we use the conditional treatment effect as the effect of interest. So I think which propensity score analysis method depends on the treatment effect measurement you want to use, and also the study design. And also, I think even the distribution of baseline characteristics and the number of confounders can play a role in choosing the propensity score analysis method.
Okay, so next question. In real clinical studies, we don't know the exact associate of covariates and outcome. How do you identify covariates associated to treatment and or outcome?
This is a good question. So can you still see my screen?
No, now it's on your home screen.
Okay. Yeah. So I think I would recommend to start using a list of possible prognostic factors from clinician. And you can check the balance of those baseline characteristics. If you see an imbalance between the treated arm and the untreated arm, then those variables could be confounders since they are associated with both treatment and the outcome. Did I answer your question?
It sounded good, so we'll move on to number 3. Which one do you think is more important, the conditional effect or marginal effect?
I think it is more like a clinical question. So in randomized studies, we usually estimate the marginal effect. But with the increasing interest in personalized treatment, I think the conditional effect is important as well.
Okay, it looks like we have 2 more if no others come in. So number 4, did you consider model misclassification in simulations?
I didn't particularly look into a model misclassification in this presentation, but I did do some simulation that I simulated the treatment, not from a logistic regression model. And I think the logistic regression for the propensity score development still performed pretty good.
Okay, and question 5, are these results published?
We published the results in a poster of the DIA meeting this year.
Okay, we just got another one. Did you account for joint distribution when conducting simulation?
The joint distribution of what? I'm sorry, I wanted to know more details to understand this question.
Okay, I'll see if a few more details come in.
Okay.
We'll wait a few more minutes to see if some more questions come in. So this is in addition to that same question. For simulation, did you assume the distribution of data was joined?
Say that again. The data joined?
For simulation, did you assume the distribution of data was joined?
So it's not included in this presentation here. So for the first simulation, I assumed the covariates are independently distributed. And for the second simulation, it's based from some a real study. And some of the covariates, they are related to each other. Did I address this question?
Yes, the person said thanks.
Okay.
Okay, any more questions coming in? We do have a few more minutes before we finish this hour. So here's another question. What application did you use for conducting your work? SAS, Stata?
Yes, so I use the SAS to do all the simulations and also in real studies. And there's a SAS procedure called a proc PS match. That was the one that I used to do the propensity score analysis.
Okay, we'll wait one more minute for any extra questions. Could you go back to our last slide with our email on it?
Yeah.
Is there one more slide after this one with our social media? Perfect.
Okay. Mm-hmm.
So as we wait, if you did want to join our newsletter, you can text ClinData to this number, 22828. And we know utilizing the propensity score analysis might be complicated. So if you do need help implementing a PS method, you can always email us at consulting@ClinDataInsight, and we'd love to help out. In regards to sharing the slides, yes, the whole webinar will be put on our website, audio and slides, and we will push out a notification through social media when that is uploaded. Okay, it looks like there's no more questions coming in, so we've gone through all that we were asked. Quinn, is there anything else you'd like to cover before we wrap up?
I just wanted to thank everybody again for joining this webinar. And if you have any questions for this presentation, so we have the slides, and we will put it on our website.
One last question came in. Is it possible to share some code for PS? Would that be a question that could be discussed over email?
Yeah, sure.
Okay, so Ashley, if you could leave your email, we will reach out to you. And that is it. Great. Thanks so much, everyone, for showing up. We appreciate you being here. Be sure to check us out on social media and subscribe to our newsletter to stay up to date with company information. We also share our events online. Thanks again for joining us. We will see you next time. Have a great day.